Okay, good evening. Good evening, everyone. So we can discuss the orthopedics questions, and it is just a recall, like as everyone say that it's just like some basic points which have been given, and we just try to reconstruct the question. Kashif, good evening, gentlemen. Good evening. So this is just recall, and we'll just try to frame the question. And if there are any inputs, you are free to provide, right? So there was like I could just gather only 4 questions, and all the 4 questions were like from the very important topics, and I would say all the 4 questions were like scoring, and there was nothing like very difficult or a very new kind of question. I think if someone had gone through the PYQ or PYT, very easily could have scored in all the 4 questions, right? And starting with the very first question, and I think this question is one which has been repeated almost every year, and it is just a coincidence that this question was there in the FMG exam as well, just in last week, right? So this question was about a person with road traffic accident, and there was fracture of the mid shaft of femur. After that, the patient around 48 hours later, he developed dyspnea, then petechial rash, and drowsiness. So the moment you have this kind of clinical presentation, I think there is no need to go into the options. Straightforward, you can jump onto the answer. So I think all of you could have marked it right. So if we just try to frame the question just as a formality, I would invite comments from your side, like what could have been the options here. What were the options here in the examination? If someone can just someone if can comment in the box, I'll be very happy. Otherwise we will go for the answer. That's not a problem. So I'm just waiting for your comments regarding the options, so that we can have the exact question, somewhat what was asked in the exam, right? So here one thing is fracture. I'll just write the points. So fracture shaft femur. Okay, clear? So this is one point which was given, and then the time duration was given, that is 48 hours later, and then the classical symptomatology, which I usually teach the student as PNR, right? So PNR is the mnemonic for that. So P is petechial rash, right? N is for neurological symptoms, clear? And R is for respiratory symptoms. So if you have this much of input in the question, I think there should be no doubt in your mind that what is going to be the answer here. So we see there is a respiratory symptom in the form of dyspnea, which was given in the question, then neurological in the form of drowsiness, and obviously petechial rash. So the moment you have this fracture shaft femur 48 hours after the trauma and PNR, I think the answer would be obviously this is fat embolism. So very rarely we see a question which is repeated in the FMG, and then the same question in almost in the same language, it is also repeated in the NEET-PG. So it's really a very rare coincidence. So the answer to this question was fat embolism. So this was pretty easy, right? And if someone can just contribute to the options, I'll be very happy. Otherwise, no problem. And if you just go for the formality, you can add air embolism or DVT or other things, right? So this is classical presentation of fat embolism. Now the second question was little bit confusing if you simply go with the history, right? So this question was about 8 years, right? So the age is 8 years, then a male, and he is presenting with limping. Now if you go with only these 3 points, you will really mix up, right? So age is 8 years, then male, and now limping. Clear? So these 3 points, especially these two, male with limping, this can be seen in 2 conditions especially. One is the slipped capital femoral epiphysis, and second is Perthes disease. But if we focus more on the age, this goes more in favor of Perthes disease, right? So this is Perthes disease. Now I am not going into the X-ray for the time being, because I just want to for you to get the question based on the stem of the question only. Rather than, if you go for the X-ray, definitely you can make out the diagnosis. But sometimes we have seen that this question is there in the exam, and in such cases X-ray was not given at all to help you, right? So I just want to make sure that you know the basic theoretical concept, so that even if you don't have X-ray, you should be able to reach up to the perfect diagnosis. So Perthes, 8 years, male, limping, and it is confused with slipped capital femoral epiphysis, which also is seen in males, and the child might present to you with limping. Now, one of the important difference is that slipped capital femoral epiphysis is seen in puberty, right? So here you can write the age as, say, 12 to 15 years. So this is one important difference between the 2 conditions. So presentation might be same, like limping in a male child, but age gives you an idea that what it condition could be, right? And for slipped capital femoral epiphysis, it can be bilateral at times, maybe in nearly 30% of cases. So anyway, that is a separate thing, right? Now if we look at the X-ray, now what we can see, painless, okay, Nivedita, painless limp, yeah, no problem. And limping is in 2 conditions only. And is there any other point apart from painless limp? Any other point apart from painless limp? And X-ray was given? Is X-ray was there in the question? No. Okay, X-ray was not there. And any other? Okay, X-ray was there, right? Chalo. So if X-ray was there, now we can discuss the X-ray as such first. Now this is the normal side. Okay, this is the normal side, and this is, we can see it is the affected side. Now what changes we can appreciate on the affected side as compared to the normal side? So firstly, what we'll see, we will see the size of femoral capital epiphysis, or what is known as the femoral head epiphysis. X-ray there, no pain and limping. Okay, no problem. And look at the other side. Now here you can see that the femoral head epiphysis is collapsed. Okay, so it is collapsed. And if I just remove this part also, you can see some areas of sclerosis as well. So this is very suggestive of some ischemic entity which has led to a kind of avascular necrosis, right? So this is what is actually the Legg-Calvé-Perthes disease, where there are ischemic episodes, right? Now this femoral head epiphysis, or you can say femoral capital epiphysis, it is cartilaginous. So what happens whenever there are ischemic episodes, under the weight of the body, it usually compresses, and therefore what we see here, we will see a deformed, compressed femoral head epiphysis, right? So this is a classical X-ray for Legg-Calvé-Perthes disease, right? So in X-ray, along with this particular history, especially 8 years males with limping, and yes, pain can be there, pain not can be there. So sometimes there can be pain which can radiate to the knee joint, so that is not a problem. But what is more important here, number 1 is the age, and number 2 is the classical X-ray, right? So this is a classical X-ray for Perthes disease, you will see a deformed, compressed, irregular femoral head epiphysis. Okay, now what you will see in slipped capital femoral epiphysis. Now here you see a classical Trethovan sign. So here you see a classical Trethovan sign. Actually what happens, suppose if I draw a line along the, like this, if I draw a line along the upper part of the femoral neck, it should pass through some substance of the femoral head epiphysis, right? Somewhat like this. This is normal. But what happens in case when this femoral head epiphysis is slipped, like suppose if this is the neck, right? So this is the neck, and normally the femoral epiphysis should be like this, okay, somewhat like this. But what happens in slipped, if this is the neck, the femoral head epiphysis will slip something like this. So it will come here. So this is known as slipping. So if you draw a line along the upper part, normally it should pass through the substance of the femoral epiphysis. But here it is not going through the femoral head epiphysis. So this is the classical Trethovan sign, which is very characteristic for slipped capital femoral epiphysis. And here you will see the normal outline of the femoral head epiphysis. It is only the position of that femoral head epiphysis is disturbed, right? So on X-ray we can easily differentiate the two conditions, and obviously this is a very highly suggestive of Perthes disease. And here you can appreciate one more thing. Look at the joint space, right? So look at the joint space. So it's something like here, but if you see here, the joint space is increased. So this is one more valuable point which goes in favor of Perthes disease. So overall, this is a classical case of Perthes disease, and I think it is not a case of developmental dysplasia of hip, because here usually if it is a case of developmental dysplasia of hip, there should be asymmetry of the groin folds. The gait is very typical. Like if it is unilateral, the child will have a lurching or Trendelenburg gait. If it is bilateral DDH, he will have a duck or waddling gait. So all those points are not here, so we can exclude DDH from this discussion. Can anyone tell me what was the fourth option? Yes, anyone? Anything about fourth option? So anyway, X-ray is quite specific. Even if you are confused in history, no need to worry. X-ray is quite specific. You can see increased joint space, deformed, compressed femoral head epiphysis, right? So that is characteristic radiological feature of Legg-Calvé-Perthes disease, which is the osteochondritis of the femoral head epiphysis, right? So I think this question is about Perthes disease. Then there was another question, and here it was a case of Meralgia paresthetica, and then it was an integrated anatomy based question where the lumbar plexus was given, and then you were supposed to answer which nerve is going to be involved in Meralgia paresthetica. Now we know that in Meralgia paresthetica, patient present to us with paresthesia in the lateral part of thigh, or sometimes you might have the word anterolateral, but usually it is lateral. And this is classically because of it's a compression neuropathy of, so it's compression neuropathy of which nerve? Yes, anyone? This is lateral cutaneous femoral nerve. And where it is compressed? It is compressed behind the inguinal ligament. Clear? And this is especially seen in people who wear tight clothes, like tight underwear, right? So anyway, so this is in short about Meralgia paresthetica. Now coming to the nerve, which is actually the lateral cutaneous femoral nerve. So we have to identify which nerve is the lateral cutaneous femoral nerve in the given question. And yes, the options which I have marked might be different, but anyway we can just take this question, right? So if you see the biggest nerve here, this biggest nerve is the femoral nerve, right? So this biggest nerve, I say C is the femoral nerve. Clear? So this is the femoral nerve. As we know that femoral nerve is the nerve which supplies the anterior compartment of the thigh. Then the nerve which is coming from above, this one, is the genitofemoral nerve. Clear? So A is genitofemoral nerve. Then this one is the obturator nerve. Okay, so this one, this is D. So this is obturator nerve, and obviously this one is the lateral cutaneous nerve of thigh. So this is the lateral cutaneous nerve of thigh, right? So there might be some changes with the arrows which was actually shown in the picture, but this is how, right? And then we have ilio-hypogastric and ilio-inguinal in the top two columns, right? So this is how, if you know the basic anatomy of the lumbar plexus, you could have easily marked this question, right? So most of the people, they know that the Meralgia paresthetica is lateral cutaneous nerve of thigh, but if you have to, if you have to just mark it on the image, then you can do it only if you know the diagrammatic image of the lumbar plexus. So lateral cutaneous nerve of thigh. Clear? So this one is the lateral cutaneous nerve of thigh, and it is compressed behind the inguinal ligament, and the patient will present to you with paresthesia, that is numbness, tingling, burning sensation over the lateral aspect of the thigh. Classically, it is very easy to diagnose. The moment a patient present to you with this complaints, straight away you can say that this is a case of Meralgia paresthetica. Now, anyone would like to add anything here? If you want to add any options or whatever, you are always welcome, but this is just a gross picture of what the questions were asked. So this question theoretically was very easy, but if you don't know the image of lumbar plexus, then it was quite difficult. Okay, and then so this is what the image is now. And then the next question was about a case of fracture tibia fibula, right? And it was managed by close reduction and a cast was applied. Okay, so a cast was applied. Now what happened later on, it was observed that the distal pulses were feeble and patient was having paresthesia. So what needs to be done? So it was about what needs to be done, but before that you have to answer that what complication have occurred. So if we just write the points, so this is a case of fracture tibia fibula. Clear? And then it was managed by close reduction and then POP cast, and after that he had decreased pulsations and paresthesia. Now these all points, decreased pulsations, paresthesia, pain, these all suggest that there is ischemia. And in terms of fracture, this is what is suggestive of compartment syndrome. Clear? So it is suggestive of compartment syndrome, and we know that fracture tibia fibula is one very common site for compartment syndrome. So apart from fracture tibia fibula, the other sites are fracture supracondylar humerus. So supracondylar humerus is one more important site, and then of course fracture both bone forearm are one more area where this complication can be seen. Anyway, that's not a part of the discussion for this question. So the case has now moved, is going into compartment syndrome. Now the question was, what needs to be done? So here I don't have exact options. Yes, one of the option must be fasciotomy. Can anyone help me with some other options if you have? So one of the option was fasciotomy. Can someone help me with other options? So that will make the discussion much organized in relation to the exact question of the exam. Otherwise I'll take the general concept of management, and then you can relate with the options which was asked in the exam. So what happens if you have managed a fracture conservatively, and if you have applied a cast, and now the patient is going into compartment syndrome? So what you need to do, the very first, I would say, like the earliest thing what you need to do is remove the cast. Clear? So the very first thing is either bivalve or remove the cast. So this is very first thing. So now that the point is that if the question is about what is the earliest or what is the next step, then obviously removing the cast seems a better answer, because that is the earliest thing what you need to do. But even if that doesn't work, then you have to go for decompression surgery. Clear? So you have to go for decompression surgery here. Now what decompression we can do, because we know that the main culprit here is the a deep fascia. So what you can do, you can cut the fascia throughout its extent, and that surgery is known as fasciotomy. Clear? So if the question is about definitive procedure, then obviously it is fasciotomy. And if the question was about what is the next step or what should be done now, then obviously you should start with removing the cast, because that might be one aggravating factor for this particular complication. So the very first thing is that obviously you have to bivalve, or better, if you are not if you don't trust the cast, better remove it and leave it as such, right? Or give it a Kramer wire splint for splintage. So if the question is about definitive treatment, then obviously we should go for fasciotomy. We have to cut the fascia, like suppose if this is the lower limb, then we have to cut the fascia along the entire extent from the top to the bottom. Then only we can decompress, right? So this is the incision throughout the extent of the deep fascia in the leg region, right? So fasciotomy has to be done. And there is one more procedure which we can do in lower limb, and that is removal of fibula. So that is known as fibulectomy. Clear? So that is just I'm just taking the theoretical part, but in terms of MCQs, I think fasciotomy has to be the answer. But yes, again, I don't know all options, so I cannot comment on sorry. So I can't comment on the exact answer, but particularly I personally feel that for this particular answer, for this particular question, the answer has to be fasciotomy, which looks very good, because that is one procedure which we have to do sooner or later, right? So fasciotomy can be taken as the answer to this particular question, right? So these were the 4 questions which I could collect, and all the 4 questions were from all the important topics, and I'm very sure all of you might have marked all the options right. So with this, we come to end of this orthopedics, recall for NEET-PG 2025. And if I get questions of some more subject, I'll try to come back again with a new recall session on that subject, right? So stay tuned, and good luck for your future. God bless. Bye bye.